Hello, my name is Lynn Goldman. I'm Dean of the Milken Institute School of Public Health, and it's my pleasure to welcome you to this webinar for the Fitzhugh-Mullen Institute for Health Workforce Equity. Today, our topic is about emergency health workforce policies to address COVID-19, and particularly the opportunity to build the public health workforce. I'm very pleased today to have with me a series of experts who are going to be presenting to you. We're going to start with Dr. Jeff Levi, who is a professor of health policy and management at the George Washington University Milken Institute School of Public Health, where his expertise has to do with the healthcare workforce, healthcare system, multi-sector collaborations, and particularly the public health workforce and public health system more broadly. We're then going to hear from Dr. Amanda Castel. Amanda is a tenured professor in the Department of Epidemiology in the Milken Institute School of Public Health. She has worked in public health epidemiology over her entire career, mostly in the control of HIV/AIDS and other infectious diseases, and teaches infectious disease epidemiology as well as doing research in that area at the school. And certainly last but not least, we will hear from Dr. Alan Greenberg, who is the professor and chair of our Department of Epidemiology at the Milken Institute School of Public Health, a renowned expert in the control of infectious diseases, especially again, HIV/AIDS, as well as a professor of medicine and microbiology at our School of Medicine and Health Sciences. So welcome to you all. And what I'd like to do is actually fairly quickly move into our presentations. I'm going to share my screen here. So beginning with Dr. Levy. And so Jeff, maybe you could give us a broad view of what's been going on with the public health system over the past few years and the extent to which our system has been prepared to deal with the emergency that we face now with COVID-19 and the challenge that has been laid before us in terms of doing basic epidemiology, the contact tracing, the testing, all the effort that's required to control this disease until we have a vaccine. So Jeff, if you would begin.
Thank you, Dean Goldman. And, this is really a story of policy choices coming home to roost. It is not news to the public health world, and it's not as though policymakers haven't been warned that the problem of pandemics, the problem of preparedness requires a consistent and growing investment in our public health workforce and our public health system writ large. Next slide, please. But the history has been one of fluctuating our investment in public health. After 9/11 and the anthrax attacks, we devoted a lot of money to building public health responsiveness, and then interest diminished. After H1N1, we invested again, and then interest diminished yet again. So the bottom line here is if you cut funding, you're going to have a smaller workforce. This is fairly straightforward, right? If you have a smaller workforce, you can't ramp up as quickly as you need to respond to a pandemic. And if you want a resilient and responsive public health system, you have to have consistent funding and a properly trained workforce. Next slide, please. So the history of, over the last decade is one where investment at the federal and at the state and local level has indeed declined. When you look at funding for the Centers for Disease Control and Prevention, which is supposed to be our lead agency in public health, funding has essentially been flat since 2008. It has, especially when you adjust for inflation. But more importantly, in the context of this discussion, preparedness funding has declined from $939 million to $675 million. Now, in the ramp up of the response to COVID-19, those numbers have increased. But you can't hire people on the fly. You may be able to have pop-up hospitals, but you can't have pop-up public health workers. And that's where the system is hurting so much. The same thing is true for state and local spending, which has essentially been flat since 2010 and hasn't recovered from the budget cuts that states and localities faced because of the Great Recession. Remember, and this is relevant to the current policy discussion, state and local governments cannot run deficits the way the federal government can. And so when revenue is down in a recession, they have to cut their workforce. And so just as we are asking public health to be ramped up, if there is not today an infusion of federal dollars, as state and local governments face dramatic losses in revenue because of the lockdown and the pandemic, we may see a similar problem as we saw after the Great Recession. Next slide, please. So this translates into real people and real jobs. In the last decade, the National Association of County and City Health Officials estimates that about 60,000 jobs were lost in public health. Think about that as, now turn that around and think about the estimates of what we need to build up the workforce to respond to COVID-19, which is anywhere between 100,000 and 300,000 people. Just think, if we had those 60,000 people there today, the capacity to respond and respond quickly and earlier would have been greater. The de Beaumont Foundation did a survey of public health workers called Public Health Wins, Workforce Interest and Needs Survey. And in addition to the lost jobs, 22% of the current workforce expects to retire in the next 5 years. So that's an additional challenge that we need to face as we are thinking about both responding to COVID and building the health system in the future. And interestingly, the workforce in this survey recognized that while they have been trained in some traditional public health elements, things like systems and strategic thinking and change management and addressing social determinants of health, those are not things that they have been trained in. And yet, when we look at the COVID epidemic and how we're supposed to be responding to it, those skills are central to it. Next slide, please. So we need to build up a workforce, some of it on a temporary basis, to respond to COVID-19, but just as importantly, we need to invest in rebuilding core public health. Next slide, please. So what do we mean by core public health? There's a growing consensus around this concept of foundational public health services and, most importantly, foundational capabilities. Something every community should be served by, that whether it's a local health department, a regional health department, or a state health department that takes on these responsibilities, we need to be able to do assessments, surveillance, epidemiology, and laboratory capacity, preparedness, policy development, communications, community partnerships, all of these things that we are looking for to public health today in responding to the COVID-19 pandemic. And in fact, when you look across the country, you find that maybe 50 to 60% of people in the United States are served by a health department that really has a robust capacity to deliver on these foundational capabilities. Next slide, please. So in a survey that was done by the University of Kentucky, there was an estimate made that if we wanted to assure that every community had a health department that could deliver these foundational capabilities, we would need to invest an additional $13 per person in spending, which is, maybe a 30 or 40% increase in current spending for foundational capabilities. That would come to about $4.5 billion. A group led by the Public Health Leadership Forum has made this proposal for a public health infrastructure fund that actually has been proposed by Senator Murray in the Senate and a different version of it by Congressman Pallone in the House. Those who are supporting the fund really believe that this needs to be a mandatory funding stream. In other words, it's automatically available every year, not dependent on the annual appropriation cycle, so that states and localities know this money will be coming in. They can hire people on a permanent basis. But there's also a recognition that we need to be public health needs to be accountable for this money. And so it will be tied toward accreditation, that you have to become accredited to continue receiving this money. But above all, having this regular funding stream means we can build the workforce that we need to deliver, to respond to these emergencies, but just as importantly, to create a resilient set of communities across the country. Because the day-to-day work of public health addresses social determinants, addresses and prevents the chronic diseases that people are suffering from, and that have made people more susceptible to the worst outcomes in this pandemic. So it is not just about being able to respond to the emergencies, but building the underlying health of our communities that requires this kind of investment. Dean Goldman?
I think that, Jeff, your talk is a call to action nationally, but I thought it would also be interesting for us to explore what is actually going on more of a local level. Now, it happens where we're located in Washington, D.C., we have a health department that functions, it is a state health department, the DC Department of Health, but it also functions as our local Department of Health. And so it's a unique opportunity to be able to see up close what's happening within public health during this pandemic. But at the same time, as a state, it does have those basic foundational components. I think the DC Department of Health is a very strong health department. Nonetheless, Amanda, it would be interesting to hear from you what it's like to be on the inside of that, involved in the COVID-19 response, the contact tracing, the case management, the efforts by the epidemiologists to be able to track the epidemic curves, as this epidemic has certainly blown past the capacity that any health department has had to deal with a major infectious disease outbreak. Maybe you could tell us a little bit about that experience. I know you could also tell us all about the epidemiology and so many other things, but I think we'd like to hear particularly what it's like for the workforce and what you see ahead of us in terms of the needs for workforce in our state and local health departments.
Certainly, Dean Goldman, and thank you for inviting me to participate in this webinar. I mean, I've been lucky enough to have the opportunity to be trained and to work in both local and state health departments. And so I do have a glimpse on how the day-to-day activities work there. I think that it's important to first just honor those public health workers. They are a committed and dedicated, hardworking, well-trained group of individuals who range from epidemiologists to public health laboratorians, and they are really critical in protecting our public health infrastructure on a day-to-day basis. Since mid-March, I've been volunteering at the DC Department of Health as part of their COVID epi response team. And I've seen the evolution of the capacity there, as well as the evolution of the epidemic and the pandemic as it's been taking place here in DC. And, generally I say that that team is a small but mighty team. Their job is really to prevent communicable diseases from being transmitted in DC. They work on things like healthcare acquired infections, foodborne outbreaks. They do routine surveillance for respiratory illnesses such as influenza. And so that's the business as usual. And unfortunately, that business as usual has really come to a halt with COVID-19 being here. And it's really putting a burden on what's already a strained system in terms of healthcare capacity. Again, I have to commend the DC Department of Health because they were able to at least develop several short-term measures to try to rapidly respond to the epidemic. And so they were lucky enough to be able to detail people from other parts of the health department to try to increase that needed capacity to get the work done. So whether it's gathering data from labs and pulling that all together, or doing case investigation or contact tracing, they've at least been able to pull from other areas of the health department. But again, that means that that work is no longer being done as well. And so in the short term, I think this was a solution, but again, as Jeff pointed out, in the long term, this really is not sustainable. Just to give you an example, I've been on the contact tracing team, and when the epidemic started in DC, we were able to relatively quickly contact cases, do that initial case investigation, and then work through their contacts and try to identify where they had been and the people that they had been in touch with, and get those people into isolation and quarantine and get them tested. But the number of cases quickly outpaced the number of contact tracers. And so we really have had to shift our efforts to focusing on case investigation and identifying those individuals that are most high risk. So whether it's a healthcare worker or a first responder or someone who's homeless or an outbreak in a nursing facility. But we've had to shift again our priorities because of the limited resources that have been available. So going forward, I think it will be essential that when we start to reopen cities like Washington, D.C. and the rest of the country, we are absolutely going to need to build back up that workforce. We need to build up the workforce to do the contact tracing and that work, but also we need to make sure that, again, that business as usual and all of the other disease control and prevention work is also able to continue as we move forward.
Thank you for that. Yeah, no, it's good to remember that those contact tracers that work in other diseases, we still have TB, we still have STDs. We still have a need to do public health screening, immunizations. There are a lot of things that have been kind of left behind during this time. And unfortunately, I think that this emergency is going on far longer than we thought it might. But I did want to turn to you, Ellen Greenberg, to reflect about this issue from a historical perspective. I think that you were very involved in the early days in the fight against HIV/AIDS, where at the time there were some things that were similar in certain ways in terms of the great dedication and commitment that was required by the healthcare providers and people in public health who often didn't know what they were really fighting in the AIDS epidemic, and the fact that it was an emergency that went on for such a prolonged period of time before we were able to find resolution and really develop the cures that were needed to help to control this epidemic. And so I was wondering if you could reflect on the lessons that were learned and your thoughts about the COVID-19 pandemic as we move forward, directions that might be taken, especially in terms of supporting the public health workforce.
Thank you, Dean Goldman. For those of us who had the privilege of working in the early days of the epidemic, there are echoes of that epidemic in the current COVID epidemic. There's certainly the widespread anxiety and fear that developed very quickly when a new viral epidemic burst upon the scenes. And although there is a test now, we all know there's not as much testing as we would hope. And it was several years before a test was available. So although we knew who was ill with HIV, we didn't know at the time who was necessarily infected with HIV. I think another similarity is the absence of treatment early on. Of course, very effective antiretroviral treatment has been developed later on. Those early years, there was less that can be offered in terms of really a focus on supportive care. There was fear among healthcare workers, among the general population, as we define transmission, modes of transmission. There was a lot of stigma against people who were infected with these viruses. And I think on the positive end, it was really the community response that was so instrumental in turning the epidemic around. And I think in many ways, that's going to be an essential part as communities rally, both as individuals and as neighborhoods, and as, you know, getting involved in the public healthcare workforce that's going to be so critical. Following up on what Dr. Levi was saying, what we're starting to see is this incredible emphasis on opening up states for economic and social reasons, mental health reasons, and as we move from mitigation to containment, that's going to require, as Dr. Castel was saying, a significant uptick in the workforce. And what's interesting and important here is that it's not a question of just doubling or tripling. It's really an orders of magnitude increase. They're estimating, I think, about one contact tracer, for example, for every 3,000 in the population. So you have to go in these local health departments from what are really handfuls or dozens of contact tracers to hundreds. And we're seeing that our school has been involved in volunteerism and trying to support local health departments in some of the surrounding counties, and also in Washington with technical assistance to help with contact case investigations, data management, answering the phones, whatever is necessary. And you really see that people are short-staffed, and there's going to have to be this tremendous scale-up that exactly what Dr. Levy was talking about on the national level and what Dr. Castel is seeing in Washington level is really true for so many local health, county and local health departments throughout the United States. So I think it's going to be a very rapid uptick in the number of people who are going to be required to be hired and trained and deployed in the field to try to get a handle on this epidemic.
This new workforce that's being created, I have the sense that this is not exactly like the job of contact tracing STD or TB, that there's a lot of case management involved, that there's complexity around the fact that many people who may have the virus are not necessarily symptomatic, but also that people may be carrying the virus for some period of time. And so what kind of people are going to need to be brought into public health to help to deal with this, and how will they be prepared to do that work? I think Dr. Levy mentioned that they don't necessarily, the people currently in the workforce, have the skills that might be required for this kind of work.
I think there are going to be different cadres of employees and people who are going to have to be brought into the fray. I know in DC there's going to have to be, the rank and file case managers and contact tracers who will be, working in the community, and therefore I think would have to have very strong community knowledge and skills and good interpersonal skills, something we've seen in the other health departments. And of course, there'll have to be managers, people with experience in public health, who are going to be coordinate the efforts of the teams of people who will be required to have this implemented. There's also a strong need for training. Some of the people hired will have public health experience, but some will have less. And I think the need to develop training activities. There's a lot of information available from CDC, as you know, Lynn Goldman from ASTO, as people are building up training modules. But I think Dr. Castel can talk about it's not just the short courses that'll bring people up to speed, but actually their own experiences as they start interacting with persons who are infected and their contacts, and then the sort of understandable questions that come up as you may be calling someone who's either sick themselves or their family member is sick. It can be a very emotional experience as well, and supporting the people doing this work, and then monitoring them and enabling to ask questions on an ongoing basis so they can improve their skills and have a resource is going to be critical as well.
Anybody want to add to that?
Yeah, I can add to that. I think in my experience, I've probably done case investigations on over 100, maybe hundreds of people at this point in time through the volunteer work at the health department. And I want to agree with Dr. Greenberg that it's not just calling people and getting information and then moving forward. You really have to build some trust with these individuals. It takes someone with empathy. It can be emotionally taxing for you as a contact tracer, and certainly for an individual if that person is sick and not doing well, or you may be talking to a family member who's a proxy because that person is hospitalized or, worst case scenario, critically ill. And so, you're not just working as a public health person, but you also are a resource. You need to be able to help those individuals get access to healthcare, to food, to testing, whatever it may be. Perhaps their family needs access to masks to be able to protect other people, or their living situation is not one that makes isolation easy. And so making sure that you can assist those individuals and get them in the right place and get them the necessary equipment, whatever it is that they need, I think is really important. I also wanted to reiterate what you said, Dean Goldman, about the fact that this is somewhat different than our traditional contact tracing around tuberculosis and HIV and sexually transmitted infections, where the mode of transmission is more intimate contact for those individuals, and obviously the mode of transmission for COVID-19 is respiratory droplets and maybe some aerosolized exposures. But it certainly means that we anticipate a higher number of contacts, and so there may be more work to be done there. Certainly going to individuals' homes and perhaps collecting swabs means that the contact tracers also need to be trained and equipped and taught how to use personal protective equipment appropriately. And then again, I think it's really important that people do have that sense of empathy and that they are connected to the communities in which they're serving, so that they can go out and really engender trust as public health workers in this attempt to try to curb this pandemic.
So I keep hearing about shortages of the supply chains for PPE, and that even some hospitals in some cases haven't had adequate supplies. What about for people in public health? Do you see that we're supplied with PPE and training for the use of PPE? And I'm also wondering, is it appropriate that people who do that kind of work would have testing? And are the people in public health able to themselves be able to monitor their own COVID-19 status? I'm just thinking that just like people who work in the hospitals, that some of them might be concerned if they may be exposed at work about even carrying it home. They may have vulnerable people in their own families that they're concerned about.
Absolutely. I mean, those are considerations that need to be taken into place as we hire these individuals, or as the health department hires these individuals to do this work. And then again, I think I want to reiterate the training issue also is really critical. Again, if people are coming from different backgrounds, we want to make sure that we're leveling the playing field and that everyone has a general understanding of public health, communicable diseases, and their roles and responsibilities.
I agree with that, Dean Goldman. I think Dr. Castel hit the nail on the head. It's when you take people, healthcare workers, they've obviously been trained either in respiratory therapy or nursing or medicine. But when you hire a large force of many people who don't have that clinical background, but yet will have patient contact and potential exposure, just like a healthcare worker would, there becomes this added need for training, for PPE, and certainly for testing of the population. So it's a genuine issue that I concur with.
So somebody who, myself has had a career in public health, sometimes it seems to me that there's a lot of indifference about public health by Congress, by society more generally, state legislatures, that they don't really notice us to any great extent, and we do seem to see declines in budgets and declines in support until something really bad like this happens. And then there's a massive expectation of what we can do, and we work really hard to do it because most people in public health are incredibly dedicated. But there's also, it seems to me, a little bit of a tendency at that point in time to kind of bash public health, that public health isn't good enough, it doesn't really rise to the occasion, because of the fact that it has been really under-resourced. And how do we get out of what seems to me to be a very dysfunctional cycle of going from indifference to very high expectations and even being bashed, and then when a crisis is over, being forgotten again? How can we sustain the interest in public health in a way that's, if you may, healthier, for the public health sector, in terms of providing some sustained support for what we do, so we don't find ourselves in a position like this again? I don't know who wants to address that. I know, Jeff, you spent a lot of time thinking about this.
Yes. Well, I think, I want to believe that this is going to be a moment of tremendous change in people's attitudes and understanding of the value of public health. I think we see that in the degree to which the American public is trusting science and evidence over politicians. in a way I don't know that we've seen before. That to me is reassuring. I think we as a public health community have a responsibility now to keep that attention focused on the kinds of resources that the public has a right to expect health departments to have, and the kinds of services people have a right to expect. I think there's an additional piece to this, which is this is not just a threshold moment of understanding of the value of public health. I also think we have a totally, the incredible disparities that we have seen in who is getting sick and who is dying has shown a bright light on the inequities and the disparities and the discrimination and the history of racism in our country in a way that has never been as coalesced as before. And I think there too, we're seeing as a country the price we're paying for that legacy of neglect. And public health has a central role to play in identifying how we resolve and remedy that neglect. And so I think both in terms of sort of the emergency preparedness side and the underlying understanding of the health of a community matters, I think those two together may change, I hope, the level of interest and commitment to funding public health going forward.
Yeah, maybe I'll turn to the other two panelists as well. What you see as signs of hope for the future, or if there are any, rays of light in here, where you see those moving forward.
I would add that as cities scale up these contact tracing workforces, that this is an opportunity for us to highlight the role of public health, and hopefully that these individuals will be inspired perhaps by the work that they're doing and really want to pursue careers in public health, that this isn't just filling a temporary need, but that there is some long-term benefit from having this more educated workforce around public health. And perhaps even if those individuals do go on to do other types of work and work in different areas, that at least they will have a general and a better understanding of the importance of public health going forward. That, again, when you're calling these people and you're knocking on doors, it gives you a different sense of the importance of the work that is done on a day-to-day basis. So hopefully that will stay with these thousands of individuals that will now be trained to help with this response.
I think the importance of community here is so powerful. Communities have to step up. It's a democracy, and people, Dean Goldman, the way to reverse the decades-old bias towards I'm sick and I'll invest in medicines, but I'm going to underinvest in prevention for myself and for my community. That's the underlying dilemma of public health, and I think this is an opportunity to shift that paradigm. I think communities are going to have to step up and work in their own communities and realize the importance of prevention. And I think that message is getting out very clearly through the United States and throughout the world. And there's an opportunity here for communities to step up and advocate for science in order to promote vaccines and cures faster than they would have happened otherwise, as happened with HIV. And I think just general, the consciousness raising that's obviously occurring about the importance of this in a media-filled era, much more so than 100 years ago in 1918. Hopefully these messages will get out loud and clear.
I can't agree more strongly. Well, before we wrap up, do any of you have any last words that you'd like to say for our audience today?
I would just want to underscore what Dr. Greenberg just said about community, and he said it several times and very eloquently, but I think that's what public health really is about, is building stronger communities. And this is not going to be a problem solved just by money and just by politicians and frankly just by public health workers. It is also going to be solved by communities. And so as long as we keep that top of mind and really commit to building stronger and stronger communities, ultimately we will have gained something from this pandemic.
What I'd say in closing is that I also resonate with that idea of strengthening the community being something that I think has been a very important lesson from this. I noticed myself in my own community, the sense of pride people have about staying at home, and even when they are making sacrifices, like the hairdresser down the street who can't work, but feels very proud of the fact that she's helping to save lives. And I think that, I personally have probably underestimated my fellow citizens in terms of their willingness to want to, support the health of the public, support the health of their neighbors, and whether it is by staying home or making masks or helping out with food. I've seen all kinds of things like that happening through my neighborhood listserv, and it makes me feel that public health is understood to a much greater extent than I thought that we were understood, one, and that there might be some long-lasting ability to have our communities united around public health. That's a reminder of what Fitzhugh Mullen, the namesake of the Institute for Health Workforce Equity, once said, which is that health workforce policy is increasingly a health equity battleground. And it does feel like a battleground right now in this fight against COVID-19.